As you know, besides aging, urbanization is a most important feature for social transformations worldwide. More than 50% of the world population is living in cities with further increasing trends. Lately, urbanization especially occurs in the developing world. It is projected that by 2015, 4 billion people will live in urban agglomerations in poor countries. Particularly big cities, so-called megacities, on which I have done some work recently, represent focal points of globalization with high concentration of economical activities and industrial production, and thus form driving forces for development. On the other hand, cities may be characterized by uncontrolled spatial expansion and unregulated land and property markets that lead to insufficient housing provision with slum settlements, large social disparities, ecological strain, infrastructural deficits, and finally to a loss of governability. Health problems in cities include pollution, traffic and noise, overcrowding, insufficient access to drinking water and sanitary facilities, and also crimes and violence, and to quickly spreading infectious diseases. Imagine Ebola, of which we have heard a lot here during the conference, would spread in a slum in a megacity on the Indian subcontinent. The Healthy City movement tries to counteract this development and promotes comprehensive and systematic policy and planning in urban areas. Healthy cities are considered cities that do not harm but improve the health of its population. The establishment of a healthy city is an important element for health promotion and prevention. A not harmful place to live is a prerequisite for a healthy development of mind and body. But what exactly are healthy cities? How do they qualify for this name? And what needs to be done to build them? This session will address these questions with 4 presentations ranging from theoretical and economical aspects over enabling information technology strategies to the practical dimension with the example of the healthy city of Warsaw. After the presentations, all 15 minutes at the most, please stick to the time, speakers, we shall have a joint discussion. Our first speaker is Ichiro Karachi, who chairs the Department of Social and Behavioral Sciences of Harvard School of Public Health. Ichiro has a background in medicine and epidemiology. He is senior editor of the international journal Social Science and Medicine and a member of the Institute of Medicine of the United States National Academy of Sciences. And the title of his presentation is Investing in Healthy Cities for Health Promotion. So Ichiro, welcome. The floor is yours.
Thank you very much. I'm going to spend 15 minutes on a quick overview of healthy cities from an epidemiologic perspective. As some of you may know, the WHO Commission on Social Determinants of Health has defined a healthy city as consisting of built environment characteristics, the retail and service environment of a city, and then the social environment that includes aspects like social capital. I'm going to speak primarily about the built environment. I don't really have, in 15 minutes, the leisure to be able to explain everything. But let's take obesity, for example. We know there are massive global inequalities in the prevalence of obesity. As you can see, the United States has the top of the list. Japan, which was where I was born, has one of the most healthiest patterns of obesity. Now, these things, these differences have, of course, caused a lot of debate about what is the cause of these national differences. What makes people in some country leaner or more overweight compared to others? And it always comes down to this debate, which people say is that because of individual laziness, there really are people. Scenes like this in America, people who walk their dog out of their car, or is obesity the result of poorly built physical environments. And this really is an actual picture from a fitness center in San Diego, where I suppose they installed the elevator for disabled people, but of course the picture shows that when you put it there, people will tend to use it. So the way that the social epidemiologist thinks about obesity is to break it up into different contexts, different levels, and at the most proximate level, which is the level of the individual, the clinician would approach an obese or overweight patient by counseling that patient about their behavior, their practices, their knowledge, attitudes, and beliefs about diet or physical activity. That's the most fundamental and micro level of intervention. But then we mustn't forget that individuals are kind of nested, or they are embedded in different contexts, whether it be the neighborhoods where they live or the society in which they live. So if we take it up one level up, then obviously individuals live in different kinds of neighborhoods which have different kinds of built environment. And that's the level of the healthy city that I think the panelists are going to talk about. But even within a country, there are differences between cities in terms of their levels of health, physical activity, obesity, diet. And so we can take it up another level. In other words, why is it that some cities in some countries appear to be more health promoting than others? And if you really want to understand the distribution of built environment, you have to go up ultimately to the level of societal planning. What is the investment in urban planning and transport policy that each of these countries have made over time? Now, if we go back to the United States, we'll see that it's one of the worst examples of chronic underinvestment in public transport infrastructure. We know from worldwide surveys of the proportion of daily trips that citizens make in each country on public transport. And among the top countries in the world are places like Hong Kong, Singapore, Tokyo. You see in my native town of Tokyo, 60% of citizens make their daily trips to work on some form of public transport, primarily the railway system. And that's because the government has invested in the building of railroad networks over time. In European cities, it's a little bit worse than Tokyo. The average for Australian cities is even worse, and the US cities worst of all. If you go back to my original ranking of obesity, this is pretty much a perfect inverse correlation of investment in public transport infrastructure and the propensity of people to be active in their daily lives. And if you take the US, for example, I don't know how many people are from America or have visited the country, you'll notice that it is very much a car-oriented culture. For example, people, instead of parking their car to obtain their junk food, they would rather drive right up to the window of McDonald's and pick up their meal there. But that's only the beginning, isn't it? If you think about how the entirety of American life is oriented toward car dependence. It's not just buying food at McDonald's. It extends to banking. People may have seen in the U.S. the ATM machines are designed so that you don't have to get out of the car. You just do your banking out of your car window. Many retail outlets, including pharmacies, have pick-up windows. My goodness, people who need prescriptions, it'd be probably better for their health if they park their cars and walk the 10 meters to pick up their prescription, instead of which they must do it through a window. And even the government is complicit in this kind of car culture. If you've visited the U.S. suburbs, you'll notice that the U.S. Postal Service has specially designed letter boxes with these large intakes so that they're designed so that you can roll up in your sports utility vehicle and mail your letter from a height of about 1.8 meters. So everything about life in the U.S. geared toward car dependence and car culture. Now, in contrast to that, I always think whenever I travel to Europe, just how pedestrian-friendly they are. And it's not really an accident. It's actually a result of deliberate town planning. The New York Times in June of 2011 picked this up. The title says, "Across Europe, annoying drivers is urban policy. I think that pretty much sums up the difference between the two continents. And the article says, while American cities are synchronizing green lights to improve traffic flow and offering smartphone applications to help drivers to find parking, a lot of European cities are doing exactly the opposite. They deliberately create environments that are openly hostile to cars. The methods vary, but the mission is very clear, which is to make car use as expensive and just plain miserable to tilt drivers toward environmentally friendly transport options. So I suppose the original intention was to go green, as it were, to save the environment. But of course, what is gentle on the environment is also a health promotion strategy as well. It's a kind of a double bottom line for society. Now, in my limited time, I just want to present the devil's advocate view, which is that everything I've said so far you could have just picked up in a WHO publication. You build healthy cities and people become healthier. That's the party line. But as a professional epidemiologist, I have to ask the opposite question, which is how much of this is actually causal. And that's the point of skepticism that all of us will confront the moment we go to meet a planner or a politician, because they all want to know the one question, which is how much of everything I've said so far is actually cause and effect. And there's sort of 2 points of view here, which is the view that access equals utilization. That is, if you can make your cities more walkable by providing public transport, attractive places to exercise, then people will exercise and they will become leaner. I characterize this as the if you build it, they will come philosophy. That's what we would like to believe. But of course, the opposite. There's a countervailing view, very possible in the realm of causation, which is that everything we observe is actually the hidden influence of unobserved characteristics. That is, that if you have walkable cities, it's because the residents have a preference for being physically active, and they lobby their politicians to get that. And of course, that same underlying preference drives physical activity behavior. And this I characterize it's all about personal taste, stupid point of view. If this is all that's going on, and it's a very commonly expressed skepticism, then making your cities more walkable is not really going to result in better physical activity and fewer cases of obesity. So how can we tease this out? I just want to, I call this the selection problem. It's true of everything about what we call the social determinants of health. I mean, we think that if we get rid of McDonald's, people will stop eating junk food. If we build railroads, people will stop driving the car. Well, we don't know, because all of this could be due to the selection problem, where we're all, the policy is endogenous to the extent that it reflects these preferences of citizens. And how can we get around to addressing that problem? So one thing that epidemiologists do is to try to, short of doing an experiment, like a randomized controlled trial, short of doing that, the thing that we do is to try to measure these preferences and then to try to condition on that, control for preferences to see whether the association remains after taking that into account. So that's my last example. I've got 5 minutes. This is a good example by 2 exercise researchers, an article which attempted to do exactly what I just described. It's called Stepping Toward Causation. What do is they surveyed 2,000 residents of Atlanta, Georgia. They assessed the built environments where people lived. These are objective assessments using GIS techniques of the walkability of different neighborhoods. And then what they did that no one else did up to that point was to actually measure and control for neighborhood preference and selection. In other words, they literally went to these people and asked them an extensive questionnaire. Why did you select to live in the neighborhood that you did? Is it because you care about physical activity spaces? Is it because of the housing affordability, crime? So they extensively asked about why people moved, and then you control for it, and then you try to observe whether there's any relationship between people's preference, their objective environment, and their travel behavior. So here's what they find. The first complicated table. The first result shows that you see the left-hand column is the assessment of objective walkability. The next column is personal preference. The far two right columns are how much physical activity they did in the manner of walking for transport or leisure. Now, the first result is that if you have a low preference for living in a walkable neighborhood, you walk much less compared to people who don't. And I call that the DAR result in epidemiology, I mean, it seems totally obvious, but it's something that we forget, and we keep on producing these studies that correlate one to the other, but this is telling us very importantly that if you don't care about walking, then you select into a low walkable neighborhood, and lo and behold, you don't walk. But the amazing thing about this same study is that if we look at it this way, if you look at the difference between low and high objective walkability of neighborhoods, what this study shows is that regardless of your preference for living in a walkable neighborhood, if you happen to be in a low walkability neighborhood, you do less walking. So if you look at this group that I've shown with the arrow there, these people both expressed high preference for living in a walkable neighborhood, but you can see the contribution between moving from low to high in terms of the objective walkability conditions. People in high objective walkable neighborhoods walk twice as much. Similarly, even if you don't care about living in a neighborhood that is walkable or not, by moving from a low to a high objective walkable neighborhood, you double your walking. This is sort of like there are small differences when you compare the distinction between people who care and don't care about walking. But this is the smoking gun of why neighborhoods and urban planning matters for health. So that's my 15 minutes, case on why healthy cities is a important avenue for health promotion. Thank you.
Well, I'd like to thank Professor Karachi, particularly for keeping to time, in fact, saving us a couple of minutes. So please, I'm sure you have questions. Please keep them to the end, and we will collect questions and have a discussion, hopefully with time at the end. So I'll turn to our second speaker, who's Mark Pearson, who's the Deputy Director for Employment, Labour and Social Affairs at the OECD. He has been head of the Health Division with a focus on how to deliver healthcare with greater efficiency. He's also worked extensively with governments, including as consultant to the US and Chinese governments. And his presentation will be on can we convince countries and communities to spend more on prevention. So please, Mark.
Wonderful. Thank you very much. Great pleasure to be here this morning. Thank you very much for giving me a chance to speak with you. Yes, I'm going to try and talk about can we convince countries and communities to spend more on health prevention. And I do stress this is and communities, because in fact an awful lot of prevention spending actually gets done at the local level. And to put this into context, let me start by just talking about health spending overall more generally. What this chart shows, the thick line is showing total health spending, public and private. The dotted line just looks at public spending on health. Right the way up to, first of all, 2009, you see health spending, on average, in OECD countries, the 34 developed industrialized countries, was going up very rapidly. 3, 4, 5% each year, much more rapidly than growth. And then the crisis hits, and health spending stops growing, both public and private. Indeed, public health spending actually declined in 2010. So the question that interested me was what actually do we cut? What did countries actually target in order to reduce the rate of growth of health spending? And, we had a series of meetings. WHO had meetings, OECD, European Commission had meetings, where ministers all agreed that this crisis, we were going to do things differently. In previous crises, what had happened was as soon as there was a public expenditure problem, the first thing that was cut was prevention spending. spending on hospitals was prioritised. And the ministers all agreed this was not the way it would happen this time around. You can see this here, even in finance ministries. When we ask finance ministries, where do they think that they should be extracting savings from the health system? They're looking at hospitals, they're looking at pharmaceuticals. Even the finance ministries don't think that there's an awful lot to be gained from trying to cut spending on prevention programs. They were convinced that the rate of return in spending on health prevention, health promotion, was higher than in many other parts of the health system. So there was a great consensus across finance ministries, across health ministries, across countries, that health prevention should be prioritised and we should look elsewhere to cut our health spending. In practice, what happened? What I've done there is to group health spending again on average across countries, and we have, if I press the red button, do I get a pointer? Yeah. Okay, let's see if that works. No, the pointer doesn't work. Oh well. If you look at spending on inpatients, yes, it did fall, but it's continued to grow in countries. Outpatient, same thing. Long-term care, not surprising that that continued to grow rapidly given population ageing. Pharmaceuticals, health spending continued to grow at the beginning of the crisis, but then when the measures to cut pharmaceutical spending came into play, you actually see drops in the amount of spending in developed countries on pharmaceuticals. But oh dear, if you actually had to pick which area of health spending was most affected by the collapse in health spending down to staying constant, no growth in health spending, it's prevention. So all those fine words about this time things were going to be different and prevention was going to be prioritised didn't actually have an impact in the end. And it was business as usual. And as a result, what I've got here is the spending in different countries on different categories of health spending, and highlighted there in red, spending on prevention. The point is, I don't think I'm going to try and talk you through which countries are spending a lot on prevention and which spending a little. The point is, all countries, prevention remains a very, very minor part of the health expenditure. And in fact, it's stuck at under 3% of total health spending. It's never got beyond 3% of health spending, and in recent years, it's been declining. So we have a problem here. We have, on the one hand, great recognition that more spending on prevention is cost effective, that's what we should be doing, and yet it doesn't happen. And I should say, I can break these figures down by local government spending or by regional spending as well, where that's relevant, and the pattern doesn't change. I can tell exactly the same story as if I add it all up at the national level. So what can we do? What can we do to convince communities, countries to do more? Now, there's many ways to answer this, and being an economist from an economics organisation, obviously I'm going to focus on the economic case for spending more on prevention. And in particular, I want to focus on whether we really know what we should be doing and whether we're giving the right sort of information to policymakers. I think this is a very good start. As for the UN General Assembly discussion on non-communicable diseases, the WHO extracted information on what were the best buys for developing, for emerging countries. And they drew on work from around the world. OECD was heavily involved in a lot of this, but many other organisations too. And I think this is a pretty good checklist of what delivers effective, cost-effective, affordable and politically viable investments in prevention. We broadly know what we should be doing in a large number of these areas. But we are still a long way from meeting the challenge. You mentioned the obesity epidemic. This is another way of showing the numbers. You focused on the difference across countries, which we certainly have there. You can see Korea at the bottom with a much smaller problem of obesity than the United States. But you can see that everywhere the trend is upwards. And indeed, that's more or less the truth for all different age groups. There are maybe just signs of optimism for one or two countries looking at young age groups. UK, Denmark seem to have reversed the increase in obesity for the youngest, for young adults, though it's a bit early to be cheering this. Still, overall, we're seeing this massive increase in obesity, and we all know the health impact of obesity. What we've been doing at the OECD with the WHO and with other partners such as RAND is to model in detail what is the cost effectiveness of in different ways of tackling obesity. And if we look at our favourite package, the package which has most impact on health and on future health spending, the most cost effective, we end up with mass media campaigns, compulsory food labelling, regulation of food advertising to children, and a few targeted areas of fiscal measures, taxes on particular foodstuffs. And if we implement that package, then the evidence is that actually we can save health spending. That's not always going to be true for most prevention spending. For example, if you invest in a school-based program to try and educate children, it will be a long time before you see any benefits, and you can't actually claim you'll save money, although it is still a cost-effective thing to do. But the point here is that over time, potentially, we could be gaining relatively large amounts of money if we actually implemented the best practice that we can find already in place across countries. And I can say the same across nearly all those areas of prevention spending that was identified by the WHO in that UN meeting. For example, when we look at drinking, nearly everywhere what we've seen is actually not an increase in drinking levels overall, but an increase in harmful consumption of alcohol. And I've looked at one aspect there, binge drinking in young women, and you can see on the left-hand side there, again, very large differences across countries, but the trend everywhere is upwards, with just these two slightly strange exceptions in England and Ireland, although from very high levels of binge drinking, it still remains a problem, of course, in those countries. And binge drinking, again, huge impacts on health and indeed a blight on especially some urban societies. Again, when we look in detail at modelling, and this time I'm focusing on the modelling that we've done just looking at the German case, some things are particularly effective at delivering cost-effective outcomes. Some are very effective at changing health. So, for example, brief interventions in the primary care sector are very good at tackling people's harmful drinking, but they are actually quite expensive. And if you really want to focus on the cost-effective ways of tackling harmful use of alcohol, you're actually looking at things like drink driving restrictions and regulating opening hours as being most likely to affect the cost effectiveness, some of which, of course, are managed locally, some of which are managed nationally. So if you're really trying to get an effective anti-harmful use of alcohol campaign, you need to coordinate at both the local and the national level. Let me quite quickly move on to my third and final area that I want to pick up on that needs to be a priority for action in prevention, and that's air pollution. And we've just produced a big study costing the cost of air pollution on health across OECD countries, 1.6 trillion. I mean, that's one of the fun things, of course, about working on health, is that you get to say very, very large numbers. $1.6 trillion is the costs of poor health due to air pollution in OECD countries, linked to a very wide range of outcomes, poor health outcomes. What I want to pick up on, and you already started referring to it, so there is a little bit of synergies, I suppose, is the role of urban sprawl in all this. And I think we really are only just beginning to realise the importance of how we actually develop our cities, our living environments, for a large number of these areas of prevention measures. You mentioned the physical activity, of course, that results from urban sprawl. That's not the only issue, of course. People also are going to drive much more if they have low-density urbanisation, and you're going to get things like reduced air quality, which links to my previous charts, but also car traffic accidents, social isolation, large number of social ills that come from that. And I think there is a real risk that if we don't take into account all those different health impacts of urban sprawl, we don't internalize them. So yes, people may well have these preferences for low physical activity, but they're not internalizing these health impacts. And if they don't take them into account, that's a role for public authorities, I would suggest. Easier in Europe, maybe, than in the United States. Let me finish then my final slide. Not just on the basis of what I've said today, obviously there's an awful lot more work going on. It seems to me that it's clear that what we can't do is just identify one little body in government and say, you're responsible for prevention, go and sort out our prevention issues. We're clearly going to be needing to actually persuade both central governments, regional governments where they exist, and local governments to have some sort of coherent action, because things like opening hours, things like controlling the urban environment are normally not in the control of central government. They're in the control of local government. And beyond that, many of the measures that we need in terms of advertising restrictions, food labelling, are going to be much easier if we have the stakeholders, the industries involved, buying into the arguments rather than being imposed on them. So I do think that what we need to do here is to actually have, in the jargon, a multi-stakeholder approach to these issues. And that certainly will include national and local governments, but needs to go beyond that. My time's up. Thank you very much.
Thank you.
Well, thank you, I think, again, for a very complimentary presentation on what we know can work, but the challenges of financing. And I think highlighting also the issue of how we bring these known interventions into not just the health sector, but in all policies, the intersectoral dimensions. And I think that takes us on to our next speaker, who again brings a more private sector perspective on these issues, Mr. Christian Korf, who's the sales director for the public sector business in Germany of Cisco, a multinational corporation headquartered in California, who brings the perspective from an IT perspective on how can digitalization enable a healthy city. So welcome. Thank you.
Thank you very much. And if you wouldn't mind, I take the microphone to move a little bit to work on my health as well while I do the presentation. So my role today is to take you a little bit onto the journey of how the digitalization is really changing the impact on health within cities. Now, as a foundation of that, please make sure that we all understand that the cities in 10 years from now have nothing to do with the cities we know today. There's a moment of truth in the industry, in society, and a rapid change. And let me walk you through that change and talk a little bit about how the opportunities in that can impact us, but also the challenges. Now, let's start a little bit with the digital aspect of it. I'm not sure whether you know, but the internet is changing at a rapid pace. Sometimes we even don't believe how rapid this change is. So I'm a child of the 80s. This is what I grew up with. So I was kind of the guy with the Adidas sports shoe, to be brutally honest. Now, if I look at society today, what do they care about? I mean, we cared about clothes, we cared about toys, we cared about a lot of things. But what are the status symbols of the society today? What is what really counts for us? It's easy. This is what we care about. And to be brutally honest, when you enter a room, the first thing you check is my connection right? Is my power here? So this is what has changed. Now, you can argue that 30 years is a long time frame. Let's go a little bit shorter in time frame. This was the election of the Pope in 2005 in Rome. And just imagine, just a few years later, it looks like this. This is the reality of a change in society. You might think this is a change in technology. No, it's a change in how we apply, how we leverage, how we use technology. This is a reality. And is this sometimes worrying also to the private sector? Yes, it absolutely is. And look at this shocking data. In just 4 years, an industry giant like Nokia was just wiped away from the market. So as an organization, you sometimes only have 4 years to look what is ahead of you. And why is that? What is the driving force behind? It basically is that we are in an inflection point that every electrical device on the planet will be connected. We even today have more electrical devices connected to the internet than we have human beings on the planet. And this is going on and on and on. And this is providing a lot of data, sometimes referred to as big data. Now, what does this big data really mean to us? And if there's only one thing you should take away from my presentation today, it's this pyramid. Because the foundation of data is pretty uninteresting. We had a lot of data for hundreds, even thousands of years. But with the access to that data in real time, it becomes information. So when you see blood pressure as a data, having blood pressure as a data in real time makes it an information for you. And there's something even more interesting, because now we can provide you context to that blood pressure, which makes it knowledge. What could be context? It could be, for example, the outside temperature. So just reading the blood pressure doesn't mean anything to you, but knowing from whom it is, how often you measure it, what is the outside temperature, what might be even the height the person is on that measures that blood pressure. That is providing you context. And with that context, you are getting something that is super important, which is knowledge. Now, with a lot of knowledge and the capacity we now have to analyze context and information, you become wisdom. You can make educated decisions in real time. And this is changing a lot of things. And just look at this little example from John Snow. In 1855, there was a cholera epidemic in London. And it took them a year to find out that this is by a water pump. They collected all of the data, they put it into context, they made it knowledge, they analyzed it, and then they realized, oh my God, we have a problem with a water pump. But it took them a year. Now that analysis in today's world can be done in milliseconds, every single moment. And this is going across all of the areas in healthcare. Today we learned about the forces you have to an ankle joint when you move, when you do a jump. You will have that data on your fingertip as you need it in real time from now on into the future. And this is giving you an opportunity, an unseen opportunity, to change feedback to people. So we talked a lot about the fact that intellectually we know that we need to inspire people to walk and not to drive to work. But in the future, we have a lot of data to motivate people by giving them insight into leading indicators. How much distance have I walked today? And people are using it because they have it at their disposal. The most attractive applications on the app stores are the health application, measuring the count of steps you're taking every day, competing with your friends, making this kind of a community working on it. But it's not only the sensor issue, it's not only the private use, it's also the professional use of that technology that gives you access to information, to knowledge, to wisdom, wherever you are. You can connect doctors, you can connect people to systems via video systems, via active data connections, and give them healthcare in real time. And that is dramatically not only changing the prevention, but it is also helping you, if in case something happened, to give you better medical care. Another thing that is dramatically changing is the miniaturization of electronics. You will see sensors in nearly everything you can think of. Those are sensors, for example, in pills that give you an indication, have I taken the pill? Have I taken it at the right time? Have I taken the right amount? So every failed medication that in today's estimations count for at least 2% of the deaths in hospitals having the wrong medication are now being monitored and giving you as a visibility in real time. Again, not only getting the data, but also in real time making the analysis and helping the team to serve in medical care better. Now, how is this changing a city? And why is this applying to a city? Because in cities, the infrastructures are growing together. And that is a unique moment of truth for all of us, to embed healthcare systems and prevention into it right from the beginning. I have to say that, for example, in Germany, we have nearly with every major city a project going on how a smart city is helping them to transform their area and their urban life in those cities. But in only a few cases, we have engagements around how can we drive prevention? How can we make sure, for example, that we help people to measure how active they are? How can we make sure that we, for example, and there's a tiny little thing. If you take a traffic light, the amount, how long a traffic light gives you access to cross the road is always standard. But what if you are an elderly person that isn't that fast? And you can't speed up while you're on the middle on the road. So how beneficial would it for you to have the traffic light system realizing that and giving you more time to cross the street? And if you're fast, if you're young, if you can move, you can easily do this faster. And you can give the cars more access to the road after you have crossed the street. All of those things will be ready in a few years from now to have access for all of the people around the world. However, it really depends on, are we making it into the industry? And the point to me that is so important is that when I read about healthcare, the only thing I'm reading is how expensive is healthcare? Who pays for it? Where do I get the funding? Whose responsibility is it? I don't think that we are approaching it from the right aspect. There is a moment of truth for us as a society. We can leverage technology to make sure that we even don't have to ask ourselves that question. We can make healthcare, we can make prevention affordable for every single person on the planet if we just use it. So let's stop talking about how expensive it is, but talk about how we can leverage the wisdom we can generate with the data we have at our disposal to make sure that we build a healthier city and that we help people to have access to not only prevention, but also a superior health care in the future. Thank you.
Thank you, Dr. Korff. Then we can only hope that the people who are creating and using this wisdom are not only sitting in front of their computers, but also being physically active like you were very nicely during your presentation. It's a pleasure for me to announce now our fourth speaker, my new friend Paweł from Poland. Paweł Ciecinski is Deputy Director of the Health Policy Department of the city of Warsaw in Poland. And Paweł holds degrees in economics and business administration. And the title of his talk will be Practical Public Health Aspects from the City of Warsaw, which is a member of the WHO Healthy Cities Network. Paweł, the floor is yours. We are very anxious to hear your talk.
Okay, thank you very much. Good afternoon, ladies and gentlemen. My name is Paweł Chęciński. I am here on behalf of the Mayor of Warsaw, Professor Hanna Gronkiewicz-Waltz. It's a pleasure to me to be with you. To start with, in this booklet, the authors mentioned that health is more than medicine. It's true. I show you that city's authorities in Warsaw know it. I prepared a short presentation about practical public health aspects from the city of Warsaw, a short presentation about healthy activity in healthy city. Following that, some photos from Warsaw. In the top left side, the Houses of Parliament. In the bottom left side, the Presidents of Poland office. On the top right side, the office of mayor, the office of mayor of Warsaw, and the last one, the highest court. And on the right, the King's Castle, and the next, the interesting building, it is a place of culture and science. It is a gift given by Soviet Union. It was 60 years ago. And park in Wilanów and the castle in Wilanów, the residence of Polish kings in the past, of course. Park Wilanów. And so Saxon Garden. It is a big park, big garden in the middle of the city. Is a good place to walk, to rest. And some basic information about Warsaw. Population is almost 1.8 million. The Warsaw is divided into 18 districts. The average lifespan in 2012 was for women 81.5 years and for men 74.9 years. And population by economic age groups, the high percent of post-production age population shows that city activity dedicated to this group must be very intensive. The next picture, the most important causes of death. The most important causes of death are in Warsaw similar to other cities in Poland. Warsaw is a healthy city, so we implement the guidelines of the WHO strategy Health 2020. The Warsaw authorities considered four main following tasks from the epidemiological situation and health needs of the citizens. Firstly, I mentioned that Warsaw is divided into 18 districts. The difference between districts in life expectancy is almost 13 years. So we had to create and implement the right activity to decrease these differences. Especially interesting is the last small point, the cooperation of other sectors of living in the city for the health of the inhabitants. That are the task of other cities sectors, not my health policy department. Some details in the following slides. Second main point, citizens of Warsaw want to feel and have the health safety. But in Warsaw it is extremely difficult to achieve the high level of health safety because we know in Warsaw there are 7 owners of public entities and of course a lot of private owners. For example, public owners, the Ministry of Defense, Home Office, Medical University, Marshal of Mazovia district, and of course city of Warsaw. So it was our initiative to create the Warsaw Council of Public Owners. This council is a consultative and advisory body of the Mayor of Warsaw for the health protection. The Mayor of Warsaw is the owner of 10 hospitals and 13 outpatient clinics. Generally, there are 73 hospitals in Warsaw. The third main point, there is a special attention to the mental health of the inhabitants. The Warsaw's program for the mental health protection is a part of governmental program for the mental health. We implement the city program in a few ways, but the emphasis is on outpatient treatment, environmental and daily. And the fourth, the last main task led to create the better life in healthy city. It isn't the traditional medicine, but all cities activity which allow people to live in healthy environment and in physical activity. Now I want to mention about Mark Lalonde, the Canadian Minister of Health in 70th years last century. 40 years ago, he created the theory of health fields. Since these times, we know that the most important for our life is the style of life. How we eat, what we eat, how we rest, how we live, and what is the level of our education and our knowledge about health promotion and prevention. In last years, in Warsaw we created and implemented many programs and strategies. The result is a better life in the city. There is not enough time to explain all programs, but I want to tell you about the bicycle traffic system. It is a Veturilo system. There are almost 200 points where citizens can borrow the bicycles. This year, the bicycles were borrowed almost 1.5 million times. I am also use these bicycles. It is not expensive. It's about 25 cents per hour. And next one. And now the next part of my presentation, the city's health programs. It is the duty of my department, health policy department. It is interesting activity because we implemented 15 programs, and our budget is the biggest than in other cities in Poland, and the number of participants is quite big. And the next picture. There are 4 groups of these programs. Three of them are dedicated to young citizens. There are 8 programs dedicated to young citizens. And the next group is the future mothers. And the third group are senior citizens. And the last group of programs, it is cooperation with NGO. And the last part of my presentation, investments support for the cities entities. We spent in the last years 265 million euro that to modernize and modernize and our hospitals and our outpatients clinic. It is a dynamics of this investment expenditure. And the main directions of investments were healthcare for elderly and mothers and children. And now a few examples. Our hospitals after modernization, our hospitals and outpatients clinic, and still outpatients clinic. Let me summarize my presentation. I hope I showed you that Warsaw is a healthy city, and the city creates the healthiest conditions for life. At the end, the Warsaw Authority did a lot, but the very important is the National Health Fund. This institution has the budget for health system and has the real power and control. In the consequence, the queue to the doctor's cabinet may be short or long. Finally, the cartoon joke by Andrzej Mleczko, it is two doctors' conversations at the outpatients clinic. I hope these patients had the long beards before they came here. Thank you very much for your kind attention.
No, well, I'd like to thank all our speakers. I think it's very important to have a practitioner view to how do we put into practice and what are the challenges of actually implementing many of the ideas we've heard previously. I think it would be particularly valuable also to hear from those involved in this kind of practice in cities. I mean, in the extreme case, we're looking at everyday Monrovia, Freetown. How do we build healthy cities in lower income contexts and contexts hit by many different problems? What are the implications of some of the lessons and knowledge we have that we've been hearing mainly from OECD or wealthier country contexts? And I think we can all imagine the huge challenges for these other contexts. So I'd like now to open up to the floor and take some questions, and then I'll come back to the panel. Please keep your questions short. Say your name and institution, and also if it's a question for a particular speaker, indicate that. But before I do that, I'm just going to say that I would like, in the wrap-up from the panel, to really address the questions I've just raised. What are the implications of these lessons of what we're talking about here for lower income context, where we know that most people in urban environments, the growth is going to be in the south. We're going to have the huge megacities that were referred to earlier. There are many challenges of building health systems, of building transport systems, of dealing with pollution, of dealing with the mobility of people and therefore the potential for spread of different kinds of diseases, but also huge opportunities in this moment of transition and of urbanization and building cities. What are the opportunities that we could be making use of, and how can we take advantage of them to pursue these ideas for more healthy urban environments? So, for example, in the current discussions on the SDGs, what could we recommend in terms of what should be in a new sustainable development agenda, and how would they be implemented to achieve the sustainable development goals? So let me open up to the floor. I can see a question here and a question at the back to start with. I hope there's microphones that will be circulated.
Thank you. Thank you. Thank you for a wonderful panel. And this question goes to Professor Karachi. I think we should look at cities at the condensation kernel of all the problems that this summit is about. Yesterday we had climate change, and I was a little bit sorry. I felt sorry that this was not mentioned. Cities are 1.5 degrees warmer. Cities need flood canals to deal with extreme events. This is the built environment. So we're not talking only about social determinants, but please link the agendas. If you take your bike, you also emit less. So this is climate policy. So very often I see that the social determinant agenda and the sort of hard climate agenda are sort of not talking to each other. What can we do to overcome this?
Thank you. I think there was a woman at the back. Oh, no, okay. You there and somebody else? Put your hands up high so I can see them. Okay, you're next.
Yeah, hello. My name is Matthias Kries. I'm a med student and the founder and leader of a global health group here in Berlin. It's more a remark than a question, and it goes to the Cisco representative. You were talking about big data, and I see a lot of advantages in there. But you were talking as well about controlling and comparing, competing your walk distance, for example. So it's more like, for example, I don't want to be controlled and I don't want to compare how many meters I'm going every day. And I think we all should keep in mind that it can put a lot of pressure on the people if they're competing like in their daily lives. And I think if we're talking about well-being, we should mention that mental health as well, and not only watching the output of those quantifying variables. Yeah, that was.
Thank you. And the gentleman 3 rows forward there. No, further behind you.
Thank you very much. I'm Nicolas Rosenberg from Scenarium Group, and I have a question for Mr. Pearson. I was wondering whether we would reach a similar conclusion if we didn't look at the expenditure on prevention, but if we look at other measures, because I'm thinking prevention, especially nowadays with the design of nudges and less financially intensive interventions, whether, especially if we compare them to long-term care, whether we would reach similar conclusions. Thank you very much.
Any other? Okay, we've got a question at the front and then another one further back.
Hello, my name is Mette Moffat. I come from Novo Nordisk, and I head up a program called Cities Changing Diabetes. This is a program where we believe that we need cities to help us live healthy lives. And we have a vision of cities where people with diabetes can live normal lives. In Novo Nordisk, we actually have all the knowledge necessary to do that, but I think the challenge is that how do we reach all the millions of people with diabetes that don't have access to that knowledge? And the program is trying to do through public-private action to actually make a difference. And we've already launched in Mexico City, where we're actually seeing that the cost of treating complications of diabetes, really being so high that they're eager to act. So it's very exciting to see that the cities are very willing to establish public-private partnerships of enabling us to provide the knowledge for good solutions, but also to actually put funding towards preventing not only diabetes, but also all other chronic diseases. My question for you is that it goes along the lines of the DAW finding from you, Professor Karachi, because how is it that, as we're talking about prevention, how can we change the attitudes of younger generations so that they prefer the healthy lifestyle? How is it that we can make sure that they understand that if they are not, if they don't choose the healthy options, if they choose the escalator over the staircase, then the consequences 20 years down the road may be diabetes or other chronic diseases. How do we, and it's almost like smoking also, how is it that you get young people concerned about effects that are not immediate?
Thank you. We'll take this one in the front and then we go back to the back. Well, I'll take 2 more. There's one over there and one at the back, and then we'll go back to the panel.
Hi, Jacob Levi from medical student from London. This is also for Professor Karachi. I was wondering, with more immigrants moving to cities and cities now having more population than rural areas, my question is, how can we encourage immigrants to keep their possibly good health beliefs? Drawing from the example yesterday, about immigrants who've left after the Fukushima disaster. Obesity has risen among them. And also a study showing Japanese immigrants into California. The first generation maintain their good health, obesity rates and low CVD mortality, but then the second generation, the offspring of this first generation, have very much similar to American rates. So how can we encourage people who come into cities to maintain their good health practice?
Thank you. There was another question. Yeah, if you can put your hand up so the microphone can see you.
Jens Stratel, a medical student from Germany. I wondered, as you just mentioned at the end, like the most urban growth is happening in low and middle income countries, focusing in small cities, and all presentations were focused on high income countries and like high technology solutions. And if this isn't just representing this big problem of lack of awareness and lack of research on these actual issue, like urban growth in small, low and middle income country cities.
Thank you. And the last question from the back on the other side.
Hi, I'm Claudel. I'm a medical student from Canada, and I just want to build up on the previous question that was asked on emerging cities. So we've discussed a lot about how we can adapt our current cities that are mostly situated in high-income countries, but I was wondering if we can hear a bit more about how we can actually help the emerging cities to ensure a sustainable and resilient structure in what they offer to the populations. And I would like to hear a bit more about this. Thanks.
Okay, thank you very much. I'm going to come back to the panel, and let me just say briefly the range of questions. There's one on focusing on being aware of the climate issues and related challenges in urban environments and how to link these with the social determinants and not ignore them. There's an issue about the role of big data, and that also alluded to the question of mental health, which I think is a very significant one also in urban environments. There's a question for Mark Pearson about alternatives to expenditures. I'll let him address that. Some information about diabetes and also highlighting the role potential of public-private partnerships, but the question about how to change attitudes and preferences, and including how to maintain healthy preferences and attitudes, for example, in migrant populations. And then the last two, going back to my comments on small cities, emerging cities in lower income countries. And of course, in lower income countries, there are small cities, but many of the problems are actually in very large urban agglomerations and megacities, which tend to be also in the south. So you've got that range of issues. So let me just start from that end, and I'll finish with my co-chair, who I think will also have some additional comments. So maybe would you like to just don't try and answer everything, but give your views on the questions addressed to you or where you have something to add to the discussion. Yeah.
Thank you. I would like to summarize the last time my presentation. In Poland and in Warsaw, we got a big chance because 10 years ago my country was joined to the European Union. It was a social and economical jump. And this support allowed us, I mean Warsaw, to create the healthy city. I mean that in poor countries, especially in Asia or Africa, it will be difficult. They need more time and more money. It's simple, but it's obvious. And very important is in the cities, in the future, it is to create the multidisciplinary strategies and programs. I tell the second one. It isn't health cities. It is not only the traditional medicine. It is all town, all cities' activity that to create a healthy city. I know that in Warsaw we have a lot of experiences that to transfer them to other countries, other cities. I do it with pleasure. Thank you very much.
Yeah, thank you. So just a few comments on a couple of aspects that have been mentioned. Let me start with the question that was directly addressed to me in terms of the big data question and how much this is forcing people into a certain corner of have to do something. I do believe it's absolutely the opposite that we need to kind of achieve as a society. Now, my compass internally is a little bit what applies to the analog world does apply to the digital world 100%. So what we wouldn't be doing in a normal world should be done in any kind of digital or virtual world. However, as soon as it is fun and people are on a voluntary basis can use it, why not giving people the opportunity, back to your point, saying that if we can only get 15% of the population in a company to use the stairs instead of the elevators, it's 12% more than today. So, and that is a good thing. That might not help the 85% that are not using it or not being inspired by the technology, but at least we got the first 15%. And then leverage the technology, and this is addressing a little bit the aspect of how can we connect environmental issues and other disciplines into this directly together, because that correlates. One aspect, for example, is, and we are talking with a German car manufacturer together to make sure that if there is a congestion in the traffic system, that they automatically route people to the German railway system, and they immediately print the ticket for the railway system and cover for the cost. And when you arrive at your destination, you automatically get a car sharing offer so that you can jump into a local car and take the rest of your journey in that car. So that brings people away from just having individual traffic just based on pure car systems, but is also helping people to understand that railway systems have an advantage and that car sharing models have an advantage for people. So using that offers basically to also reduce pollution, to make sure that the environmental aspects are covered on top of this. Another aspect is, for example, the lighting systems. So making sure that, and by the way, the biggest consumption of energy in a city is the lighting system today. If you can just reduce lighting by being more adaptive, that could help you dramatically to have environmental aspects embedded into this. So I fundamentally believe this could help. The last aspect I want to mention, and this is something we shouldn't allow as a world society, is even thinking about that emerging cities should not or could not have access to the technology of tomorrow. I mean, if there's one mission we need to be on as a society, we need to make sure that we give even emerging cities, even cities that believe they can't afford the technology today, we need to step up and making sure that we help them to have water supply, to have waste management, to have electricity, to have access to information at their disposal, because those are the ingredients of a healthy city of tomorrow. And we need to invest into that basically on a worldwide basis to make sure that we can't allow even the thought that those are excluded from having access to those technologies, because this directly impacts the healthcare system, and this directly impacts how people are cared about in those cities.
Thank you.
Well, let me do roughly the same thing by focusing, first of all, on the question I was specifically asked, and then answering commenting on another couple of questions. The first one, are we looking too much at spending on things like prevention, and would we get a different picture if we tried to count the amount of effort going on in countries if we looked at some other matrix? I mean, I suppose that's the key point. I do like counting things. I mean, I think if you're going to compare countries, let's not do it by anecdote. Let's actually look at something that we can count in order to be able to compare. And that's why we do tend to focus on things like expenditure. That's not to say that there aren't other things going on in the prevention world which probably cost
very little and yet which will have impact. You mentioned nudge in your question. I do think some aspects of nudge policies are promising and indeed look as if they're cost effective. Equally, some I think by now we know aren't working and aren't cost effective. But there certainly are exciting things going on which don't cost much. I look at plain packaging rules coming in for tobacco in Australia and now being proposed in France. Things like France talking about bans on smoking in public parks and various other measures going on. So I don't think I want to give an entirely negative effect that somehow countries have given up on prevention. Nevertheless, if you look at what we really want to affect, the outcomes, I showed the charts on obesity, I showed the charts on binge drinking by women, I could have shown charts on smoking where the rate of progress in many countries has fallen, although it is still going down, the rates of smoking. I don't think that we can claim that somehow we've just got more effective in our prevention policies, and therefore I do worry when I look at the fact that there is less spending going on during the crisis years. Just to pick up on another couple of issues, there was this question about how we change the attitudes, particularly of young people, to have healthier lifestyles. I mean, this isn't something that we're coming without evidence. I mean, there are a lot of studies which have looked at the effectiveness of programs to influence young people. And so we do have some clear ideas, or reasonably clear ideas, on what works in various different areas. I mean, what we've learned is that simple, relatively cheap measures to say, alcohol's bad for you or tobacco's bad for you can even be counterproductive because they end up glamorizing the forbidden. And in fact, what works with young people needs to be a much more in-depth, structured conversation about the risks and how you should be considering the risks. It's therefore more expensive, but more effective. And one of the problems that we have there, coming back to the expenditures point, is that any measure targeting young people, you're talking about the benefits being a long way in the future, often decades in the future. And I think, unfortunately, that's often why we see prevention spending being reduced in the crisis. The spending is now, the benefits are a long way in the future. The benefits far outweigh the costs. It's going to be a different minister that will gain the political credit for that in the future. And we have not, as a health community, managed to make that sufficiently understood at the politicians understand it, but they don't know how to overcome it at the population level. And we don't communicate that well enough at the population level. I'm talking too long. Very quickly on less developed countries and what we can learn. I think, just again on the cost effectiveness of prevention, some of the most cost-effective measures in developed countries are involving the health system, so making sure that the health system picks up prevention measures more effectively, primary care physicians and so on. What we know from the evidence is that that's less effective in developing countries, and we need to rely much more on non-medical, non-health related structures, such as public information campaigns involving local communities much more. I could go on, I'll stop there.
Thank you.
So I think with respect to the question about the environmental movement contrasted with the public health movement, that's a very good one. I think the environmental movement have had a jump on public health. I mean, they have the environmental impact statements, which really have incorporated into policy making impacts on the environment. The problem is that health has not been at the table, and I think there are two things that can overcome that kind of disconnect. One is the solution to implement health impact assessment in addition to environmental impact assessment. By bringing in health impact assessment as a way of bringing in the public health voice and consequences to policy making, such as what would happen if we built a new motorway to local health, the local health of the local population. I think we also have a deficit in the training of public health personnel. Many public health people trained in public health are unaware of how to make change in the environmental sector. I always think of my students who, when I question them, they really have no idea how public health voices are incorporated into urban planning decisions. That's a very local process in the United States, for example. When a locality decides to build a new road or build a school, there is a town planning board which gets together to discuss the siting of that new building, and they take into consideration land use and access to transport and other things. But people in public health never bother to find out how to get onto that board, when do they meet, and how can they make their voices heard. So I think there's a training need among public health professionals. Regarding knowledge, attitudes, and practices, the point of my talk was that those are not enough. You can sort of fix information asymmetry to some extent by educating people about about exercise, but it's not enough. The point of my talk was that you also have to intervene in the environment, or what behavioral economists call choice architecture. If you really want to make people ride their bikes, you have to make it easier by providing bike lanes, by providing parking spaces for bicycles near local train stops. These are things that are taken for granted in the Netherlands, in Sweden, and elsewhere, but not in the United States. So you have to change the environment to make things work. And that, there's a connection between that and architecture as well. You want people to take the stairs instead of the elevator. Think about where the stairs are located in a typical building. Most of them, including at the Harvard School of Public Health, the stairs are invisible. They're off to the side. They're dark. They're unlit. And the first thing that people think of when they come into the building is they make a beeline for the elevator. If you change that architecture, it literally is a kind of choice architecture to make healthier options the default option. Lastly, regarding immigrants and obesity, that's also a story about environments. All of our data show that the main cause of obesity in the United States is the obesogenic environment. We published a very interesting study of migrants into America where we showed that no matter where they came from, whether they were immigrants from Asia or from Europe or Latin America, they all put on weight when they came to America. And we call it the America 10 effect, which is that roughly after 10 years of living in the United States, the average person puts on about 10 pounds. And that's an effect in which people of differing lifestyles and genetic backgrounds all experience this effect. As I was really telling us that if you really want to address obesity among both immigrants and the native born, you really have to pay attention to curing the environment as opposed to curing the individual. And that's really what Healthy Cities, the message of Healthy Cities is about, is saying, go beyond the individual, look to the environment, provide choice architecture.
Thank you. And Professor Kramer, would you like to make a few?
Yeah, we already exceeded our time, so I don't want to talk much. Many things have been said. I think the point that megacities or big cities are not alike is a very important point. You raised it, and I think we have to understand we cannot apply recipes that apply to all cities. We really have to study especially the big cities and the urbanization processes in the developing countries, in the poor countries much more, put this on the agenda of our education and put also money into research to study this further. I had the opportunity to be part of a big priority program about megacities and health with geographers, climatologists, urban planners, and we put out a book about this also in Springer, so I don't want to end with a commercial, but certainly this book is also here. You can certainly look at it. It may be interesting perhaps. And I think what has not been mentioned is also the participation issue. The participation of the population in all these Healthy Cities activities that was created already in the 80s, this movement, and empowerment and participation is a very important aspect. And also to have good surveillance systems to set out the priorities for the different regions. They may be very different. You don't have basic sanitary facilities in certain parts of the world, and in our developed countries we have other problems, and really you have to understand these differences. So I think we are done with this session. We are very happy that everything worked out, I think, fairly well. We thank very much the speakers, the discussants, the whole audience for coming here and participating so actively. And I would like to say also the President, Jose Ganten, told me that there won't be a break. We will directly continue into the closing ceremony. So thanks again for participating.